October 15th, 2020 PHBC meeting timed agenda. What's the pleasure of the committee?
Move approval.
Second. Second?
Second.
Been moved by Ms. Brown, seconded by Ms. Taylor. Any discussion on the motion? Seeing none. Ms. Hopper, can you please call the roll?
Thank you, Mr. Chair. Margaret Brown.
Aye.
Henry Jones.
Aye.
David Miller.
Aye.
Irene Ortega.
Aye.
Ramon Rubalcava.
Aye.
Teresa Taylor.
Aye.
Donda Wesley.
Aye.
Karen Green Ross for Betty Yee. I do not see Karen in yet, Mr. Chair.
Okay.
I've got Margaret Brown making the motion, Teresa Taylor seconding it. And as of all the votes, they are all ayes.
Very good. Thank you. Moving on to item 3 is the executive report. Mr. Sweeney, Mr. Molds, who's going first?
I'm going to go first, Mr. Fechner, if that's
Very
okay
good.
with you.
Perfectly
fine.
fine.
Good morning, Mr. Chair and members of the committee. Anthony Sweeney, CalPERS team member, and it's great to be with you again to share about activities and trends in customer service and in education since I last had the chance to appear before you in June. I'm pleased to report that our teams continue to successfully telework and meet our customer service performance goals. Within CSS, more than 90% of the branch is consistently working from home, and the number of our contact center team members working from home is up above 95%. Our benefit payments remain timely, and our customer satisfaction scores continue to be strong as well. These results are encouraging, especially as we have some team members periodically faced with a variety of challenges, from remote connection issues to managing distance learning with their children, to providing care for family members, and even some evacuations from the recent wildfires. I'm impressed with the team's resiliency and flexibility in balancing the changing priorities in home and life while also demonstrating unprecedented commitment to our customers and meeting all their needs. Related to customer education, the last time we met, I shared with you that we'd be conducting our first virtual CalPERS Benefit Education Week at the end of July to continue educating our members despite our inability to have large in-person gatherings. I'm happy to say this event had over 3,000 attendees, many who participated in multiple member education sessions. This was a remarkable turnout for our first event. Overall, our class satisfaction for the week was an astonishing 98%. And as a result, I'm extremely proud of this, and especially considering it was our first attempt at a virtual event of this magnitude. We're currently exploring our opportunities for another virtual CB week before the end of the calendar year. Speaking of disasters and disaster assistance for our members, between the wildfires and hurricanes, it seems everywhere we're experiencing these disasters that are currently impacting our members. I want you to know that we're proactively working to meet their needs during these uncertain times. We have team members identifying post office closures, identifying which retirees are receiving paper checks and might be impacted, and reaching out to all those members and trying to enroll them in a direct deposit option or identifying alternative means to deliver their past or future retirement checks. Due to the circumstances, many of which involve evacuations, it can be difficult to get in touch with these members, but we've reached out to over 200 members. We leave messages if we can't reach them directly, and we've also informed our contact center with all the information to look out for their calls and make efforts to get them their funds. We're also providing assistance to our employer community. As you know, in March, the governor issued an executive order lifting some of the restrictions for retired annuitants. And if they were hired to provide adequate staffing as a result of the pandemic, there were certain exceptions for those individuals. And our post-retirement employment determinations team has worked through over 1,000 exemptions that have assisted our employers in getting those retired annuitants back to work. For our active members, we have recently released our electronic annual member statements, and this allows them to review their accrued service credit for the year and contributions, and those are now available in their online MyCalPERS account. We inform our members that those statements are available through various means. That includes email and social media, as well as announcing it in an upcoming issue of our Perspective newsletter. The service credit they earned is based on employer reporting throughout the year, and this will help them if they're close to planning for retirement. As a result of efficiencies over the last couple of years, we were able to release these in August for the second year in a row, as opposed to October or November in previous years. Lastly, I want to inform you about some retirement trends that are amongst us related to COVID, social unrest, the disasters, the PLP program, and a few observations around what's been happening with those retirement inceptions in the recent months. From March through July, our overall retirements have decreased 23% compared to the same time last year. However, we have seen an increase in state employee retirements of 14%. That would reflect that our public agency and school members are decreasing their retirements at even a greater rate. We suspect the bargain PLP program and corresponding pay reduction is a factor in the increase for our state members. And we are aware that school members are being paid through the end of the year, so we may see more school retirements. They're most likely holding on until the fall period of time, fall and winter. So we'll keep tracking these trends and update you further as we know more. So in conclusion, I just want to thank our team for working so hard to deliver on our mission of serving our customers, especially during these difficult times. And I'd like to thank the board for your support. And this concludes my report, and I'm happy to take any questions.
Very good. Thank you for your report. I see no requests for questions, so thank you very much.
Thank you.
Mr. Molds.
Okay. Good morning, Mr. Chair, members of the committee. Don Molds, Chief Health Director. I have two items for the committee today. The first is an update on our work with the health plans to gather COVID-19 data among the CalPERS health membership, and the second is 2020 enrollment. First, I'd like to update the committee on data we've been gathering with the health plans to better understand COVID among our members. Early on, we didn't have a clear picture of COVID cases due to coding and claims lag. We typically at CalPERS see claims about 90 days after they first come in with health plans. But what we heard from the plans was that CalPERS members' data was tracking with the state's COVID-19 trends, and that remains the case today as well. The data provided from the plans that we've gathered represents roughly 90% of our membership, not including the association plans, represents March through July numbers, so it does not include August. Here's the data, what the data shows. Roughly 84,000 COVID tests have been performed on CalPERS members. There were fewer tests in March and April, about 2,500 and 6,500 tests respectively. Fewer tests were performed in March and April when state and federal testing guidelines were more restrictive and the prevalence of COVID was lower in California. Testing then increased as we saw surges of cases throughout the state to roughly 19,000 tests in May and 29,000 tests in June, and then 26,000 tests in July. The positivity rate is another number that we're tracking. The positivity rate is an important measure because it gives us an indication of how widespread COVID-19 infection is and whether levels of testing are keeping up with the levels of disease transmission. For March, April, and May, prior to the post-Memorial Day surge, the positivity rate among CalPERS members was about 5.4%. So this means that 5.4% of the diagnostic tests processed in those months were positive for COVID-19. The positivity rate increased in June and July to 8.7%. Again, very similar to what we've been seeing statewide on the positivity rate. Our COVID-19 hospitalization rate in March and April and May was 15.9%. It then decreased in June and July to 7.5%. So these rates also correspond to what we're seeing statewide, but it is an encouraging trend, obviously, to see. Just a couple of notes about this plan data. One is that reporting is based on claims and may not include COVID tests performed at state testing sites or also by the CDC. Also, the number of tests may include CalPERS members who were tested more than once. Given our size, we know this information is of interest not only to our members and stakeholders, but also to other state health agencies and large healthcare purchasers. We will continue to collect the data from the plans and provide regular updates to the board and the stakeholders. Collecting this data also reminds us how personally this pandemic has impacted our members and their families. And while I just reported some large numbers and rates, I'm very aware that these numbers represent individuals and lives, in many cases irrevocably changed. For these reasons, we're working closely with our health plans to ensure our members continue to feel safe while seeking health care and remain as healthy as possible, especially through the winter months this year when COVID and flu are going to be circulating together. Our health plans are redoubling their efforts to get members vaccinated against the flu this year in a reimagined, socially distanced way. My second item is open enrollment. I want to remind our members that open enrollment starts next Monday, September 21st, and ends October 16th. This is the time to make any plan changes or add or remove dependents. Yesterday, member health plan statements became available in my CalPERS accounts or were mailed to members who requested that. Various other open enrollment information is also available, and we have regular communications planned over the next month, as do our health plans. We have a media agenda today, so I'm going to stop there. Today, I'm going to kick things off with the discussion of a proposed one-year extension of our pharmaceutical benefit manager contract with OptumRx. After that, you'll be hearing from Marta and her team about the modeling work they've been doing over the last few months to explore risk mitigation options. She also plans to discuss the robust stakeholder engagement efforts that she'll be leading on the issue over the next couple of months. After that, you're going to hear from me again about long-term care. So that concludes my remarks, and I'm happy either to take questions or to move straight into the discussion of the OptumRx contract.
Okay, I'm not sure we have any questions right now. I see we do have some callers for later on, but before we get into some of the discussions, we do have a request to pull something off the consent item calendar. So do you want to do this part now, Mr. Molds, or further in the agenda?
You know what, it's at your pleasure, Mr. Chair. If it's, what's the item?
They want to pull item 4B. Yes.
Yeah, Kim, we need to promote Kim Malm, who's been working on this with me.
My question is, do you want to continue with your report now, or do you want me to go on to item 4 and then get your report?
You know what, I'm good either way. Why don't I continue, and why don't we just take it in order?
There you go.
If that's All right. Okay. So shall I go ahead with the Optum?
Yes, please.
Okay, great. So first item we have for you today is proposed extension of the contract with our pharmaceutical benefit manager, OptumRx. The proposal would extend the term of the contract by 1 year with an option for a second year at CalPERS' discretion. As
Just a second, Mr. Moltz. Don,
Yep.
if you could wait a second.
Sure.
Isn't that agenda item 6A that you're talking about?
I am.
So we've got to get to 6 first.
So
We're on 3. We're currently on item 3.
Correct. So those are both action consent items.
That's item 4.
Right.
So we need to take it. We need to take them in order. So we're going to go to item 4 first.
Okay.
That's the
Sorry
approval.
about that.
All right. It's approval of the June 16th committee meeting minutes. There's been a request to remove item B, which is the review of the delegation. So the action consent item before us is the approval of the meeting minutes. What's the pleasure of the committee?
Move approval. Move
And
approval.
second.
All right. The move by Mr. Rubalcaba. Is that who that was?
Yes. No.
And the second is Ms. Brown.
Yes, sir.
Very good. All right. Any discussions on that motion? Seeing none. Ms. Hopper, please call the roll.
Margaret Brown,
Aye.
Henry Jones,
Aye.
David Miller,
Aye.
Elena Ortega,
Aye.
Ramon Rubalcaba,
Aye.
Teresa Taylor,
Aye.
Shonda Wesley,
Aye.
Karen Green Ross for Betty Yee.
Aye.
Mr. Chair, I have Ramon Rubalcaba making the motion, Margaret Brown seconding it, and it's all ayes.
Thank you. Motion carries. Next item that we pulled was item B, review of the committee delegation. Ms. Brown?
Thank you, Mr. Chair. In reviewing this committee delegation, there's a lot of strikeouts here. And I realize that some of this is just redundancy. I know that we've been doing this as part of our make it simpler to understand, but I'm not sure why we're crossing out resolved E, because that tells us or reminds us that the committee must discharge its duties solely in the interest and for the exclusive purposes of providing benefits to participants and their beneficiaries, and it goes on and on and on. But it also says that we must discharge our duties with care, skill, and prudence. And so I'm wondering why we're crossing that out.
Thank you. Ms. Mom?
Thank you, Ms. Brown. What I did was copy exactly what you did with your governance delegation and your risk delegation in order to follow the work stream 3 of making things simpler. So it was only removed because it's the same thing that you removed under those other 2 delegations.
Great. So by removing it, we're not removing our responsibilities. Is that correct?
That's my understanding. And
Absolutely not.
Yeah.
Thank you
If
for
I
that.
may, this is Matt Jacobs. This was deemed to be just simply duplicative of provisions in the Constitution and throughout the governing documents otherwise. So it was just simply an effort to streamline this document and make it more readable.
With that explanation, I would move approval. Thank you.
Thank you.
Thank you. Do we have a motion? Is there a second?
Second.
Second.
Been moved by Ms. Brown, seconded by Mr. Rubalcaba. I do have Mr. Rubalcaba for a question or comment. Oh, waved it off. Okay. Any discussion on the motion? Seeing none, Ms. Hopper, please call the roll.
Margaret Brown,
Aye.
Henry Jones,
You're muted.
Aye.
David Miller,
Aye.
Elena Ortega,
Aye.
Ramon Rubalcaba,
Aye.
Teresa Taylor,
Aye.
Shonda Wesley,
Aye.
Karen Green Ross for Betty Yee, Aye. Mr. Chair, I have Margaret Brown making the motion, Ramon Rubalcaba seconding it, and I have all ayes.
Very good. Thank you. Motion carries. Takes us to agenda item 5, the information consent item. Having no request to move anything, we'll move on to item 6. 6A is the pharmaceutical benefit manager contract with OptumRx. Mr. Mould, here we go.
Excellent. Good morning, Mr. Chair, members. Don Mould, CalPERS Chief Health Director. First item we have for you today is a proposed extension. Shouldn't say the first item. I should say this item is a proposed extension of the contract with our pharmaceutical benefit manager, OptumRx. The proposal would extend the term of the contract by a year with an option for a second year at CalPERS' discretion. As part of the terms of this agreement, OptumRx has agreed to transition beginning January 2021 to an acquisition cost-based contract. The monetary terms are also an improvement on our current contract. There are a few reasons why we think this is beneficial. It's beneficial to extend the OptumRx contract under the proposed terms. First, and most importantly, it allows us to maintain continuity of our pharmaceutical benefit manager relationship for the likely course of the COVID-19 pandemic. This has been an issue of concern for CalPERS, given the challenges we've been seeing in the pharmaceutical supply chain, as well as difficulties our members may face if we were to transition to a new PBM during the pandemic. As you know, our current contract is set to expire in about 15 months, which means that if we were to recompete the contract now, a PBM transition would start next summer. So I'm hoping COVID will be in the rearview mirror by then, but we can't know that, and I would not bet on that. As several of you have experienced, PBM transitions can be bumpy, and the environment we're in right now is an extremely challenging one for both acquiring drugs and for distributing them. There were very real supply chain challenges created when the pandemic shut down pharmaceutical manufacturing sites earlier in the spring in China and in India, and when runs on drugs being touted as COVID cures were creating shortages for people who actually needed them. On the distribution side, many of our members have migrated from retail to mail order pharmacy, which is the safest way to receive pharmaceuticals during COVID. We've been monitoring these changes closely, and we think that Optum has done a pretty good job of managing them. We worry about our ability to ensure smooth delivery of drugs if 2021 is a transition year, however. The proposed transition to an acquisition cost-based contract is another important benefit of the extension. As we discussed at the offsite in July, an acquisition cost-based contract wherein our PBM would be compensated for costs associated with procuring and dispensing drugs rather than on the margins they profit from through drug manufacturer rebates and acquisition price spread is the future for CalPERS. At least we see it that way. It is far more transparent than the traditional PBM contract, and it allows us the flexibility to integrate other cost-saving initiatives, reference pricing, for example, and to participate in CalRx when that is up and running. When I talked to you about acquisition cost-based pricing in July, we were looking at building it into the RFP for next year's contract. Starting it a year earlier, as is proposed here, gets us transitioning earlier and gives us time to work out any kinks before we move into it permanently. Last, this proposed extension comes with monetary improvements over our existing contract. It improves our price guarantees for both 2021 and 2022 and offers other cash concessions. We're seeking your approval of this contract extension along with the more favorable financial terms. I'm happy to answer any questions.
Thank you very much. I have Ms. Brown.
Thank you, Mr. Chair. Thank you, Mr. Moulds, for that, the information and the work on this. I think the transparency is excellent. I did have a question in your write-up. You talk about we will have the ability to tailor our formulary. And so I'm wondering, for our members, we always worry when we start talking about tinkering with the formulary. So can you tell me what you have in mind? Because, you know, changing the formulary really upsets people and their budgets if we're going to, you know, take people from their regular drug to a generic or something else, or maybe not even cover it, move something up a tier. So can you tell me a little bit about what the plans are for tailoring our formulary?
Sure, and we have I should add that we have a basic authority for approval of formulary already. But what this really does is allows us to move to alternative sites where we can potentially get better deals on drugs. So we could conceivably, for example, migrate into CalRx and purchase drugs from the state of California if the generic drugs they're offering are in fact the lowest priced drugs. So we, we take all of that into account whenever we're making any formulary change. We make formulary changes constantly over, over the course of a contract. There are periods each year when we review the formulary because obviously the treatment protocols will change, new drugs come on the market, so we're constantly looking at new ones. And obviously we take, I shouldn't say obviously, we take the pain associated with changing drugs and the anxiety associated with changing drugs into account. Having said that, one of the goals in the longer term is to transition people who are on high-cost drugs where there are lower-cost alternatives that are clinically equally efficacious to those drugs. The key in making those transitions is communication and a robust appeal structure if members feel like for whatever reason an alternative drug is not doing the job that it used to. So that's the sort of basically how we handle the formulary issues.
I appreciate that explanation. Given COVID-19 and how many of us are not going to our doctors, even the online or the telehealth, those changes can be complicated. So I hope we're going to keep those to a minimum for our members. Thank you for that explanation.
Yeah, thank you. That's a good point.
Thank you. I have Mr. Miller. Mr. Miller? Go, David. I think you're on.
There we go. Nope. No, I had no comment. I was just mentioning, I just posted a note that my video keeps freezing, and it looks like Shonda's video and a few others are freezing at my end as well. And when it's frozen, I can't speak, like just happened right now and has happened when I've tried to make motions and stuff.
Very good. Thank you. Ms. Green-Ross.
Just want to thank Dawn and the team on this negotiation for the new contract. Good to be in the driver's seat. Hopefully this is a trend for all purchasers of pharmaceuticals. Has it been standard that most of these companies have done the rebate process versus the one we're heading into, which is more transparent?
Yeah, we will be on the cutting edge with this one. So the federal government has acquisition-based contracts. There are a few other purchasers, nobody our size. Yes, the standard is rebates and acquisition spread as the primary mechanism for PBMs to make their money, and we just think it's a lot cleaner to be paying them to find the drugs and to distribute the drugs, because that's what we're focused on. So thank you for that, and yeah, this is relatively novel.
Well, that's what I wanted to, on behalf of the controller. This is just amazing and commendable to be on the cutting edge. This is the right direction that this should go. So thank you very much for all that hard work and getting this worked out. This is going to be great. Thank you.
Yeah, and thanks to the team, the contracts team, obviously, and Marta, and to the legal team that helped with all of this.
All right, thank you. Mr. Rubalcaba. You're muted, Ramon.
Sorry, thank you. Thank you, Don. Thank you, Mr. Chair, for calling on me, and thank you, Don, to you and your team for this new approach. You mentioned earlier that this new platform will facilitate going to CalRx, but also I think you mentioned in your memo that it's also we have other innovations. For example, the biosimilar first strategies and the reference-based pricing. So will this new platform also facilitate moving to those initiatives?
It will. It's a more neutral platform, so it's much easier to move to those. We've obviously, to Ms. Brown's point earlier, we've postponed the reference pricing initiative during COVID because we just felt that it was there's enough transition for our members right now as is, and we couldn't engage in the communication initiative with providers that we needed to, both providers and our members that we needed to do it without bumps. So we've postponed that. We're moving forward with the biosimilars first initiative, which doesn't actually, which only affects new scripts going forward. We're beginning that in January. So yeah, it will facilitate that.
And another big favorable item you mentioned is that it will sort of break up the black box. There'll be more transparency on the drug prices. What systems in place do we have to make sure we are getting the best price and that the black box keeps getting broken up, I guess?
Yeah. So that's a great question. I mean,
and if I could add, Don, if I could just add, if you can answer both, and how do we make sure that those savings are passed on to the members? Thank you.
So, yeah, sure. So the big improvement is that we will actually be seeing those prices. Marta, if you have anything to add there, jump in. But we will be in a position to see what the acquisition price is for particular drugs and to verify that that's our price.
Yeah, this is Marta. So previously when we'd receive a claim, it would be basically a net claim. So we wouldn't know what the acquisition price was, the element of it that was a rebate, how much of it was really for the PBM for the distribution and whatnot. And so now in this claim, you will actually see the acquisition cost transparently for every transaction. And so on the surface, we can see exactly how much the drugs cost us and our members. And the second question, Mr. Rubalcaba, you asked was, how do we ensure that the savings are passed along to our members? So when our total PBM spend goes down, we can reduce costs as we build it into those health plan rates. And so that's how the cost reduction is felt by our members.
Thank you very much. And again, congratulations on the good work. And unless there are any other questions, Mr. Chair, I would move that the recommendation.
Thank you. There's a motion. Do we have a second?
Second.
Thank you. Moved by Mr. Rubalcaba, seconded by Ms. Brown. I do want to also thank Mr. Moles and all the staff that were involved in putting this together. It was a lot of hard work and very thoughtful work. So thank you for the job well done. We do have a couple of requests from the public to speak. Mr. Fox, I do believe you have a couple of callers.
Yes, sir, Mr. Chair. First off, we have Mr. Tim Behrens from CSR.
Thank you.
Thank you, Chairman Falk and members of the committee. Tim Behrens, California State Retirees, speaking in favor of this motion. I really want to thank Don for his response to the board member's question about the formulary. That was good news that you shared. I would like to say some positive things about OptumRx. They actually stepped up after they started on a bumpy road have stepped up and together with the CalPERS health team and their leadership, they have been very responsive to our members regarding their medications and any questions they might have. And for the last couple of years, they've been sending their staff and pharmacists to all of our board meetings, doing free cholesterol training and answering any question anybody in the audience had about their medications and cost of medications. So thank you very much.
Thank you, sir. Mr. Fox.
Mr. Chair, the next person we have to speak on this subject is Mr. Larry Woodson.
Thank you.
Good morning, Larry Woodson, California State Retirees. Thanks for the opportunity to comment. I'd like to go back and just give some thanks to the health team for, on item 4B, review of committee delegation. The initial draft presented a while back on that. We had problems with. Kim Baum met with us. We discussed it, and some of our concerns were, most of them were addressed. So I thank you for doing that. CSR, as Tim said, we do support this one-year extension. It makes sense for all the reasons that Don articulated. We have a little concern about the acquisition-based contract, and I'll make the point. We support the principle of doing away with the rebate system. Back in February 2019, Trump's Health and Human Services program proposed a rule to eliminate PBM rebates nationwide. The PBM lobby strongly rallied and opposed that rule. It was withdrawn. But one of the PBM talking points was that rebate elimination would result in higher drug prices for the consumer. And my concern is, to the extent that that's accurate, is there risk to CalPERS by eliminating it? I mean, I liked what I heard about knowing the acquisition costs. I'll point out that that's different than the drug manufacturing cost. And I'm not sure, it really depends on how honest the PBM is in providing acquisition costs, I suppose. But the other thing I like about it is you do have, with a one-year extension, you can evaluate the impact on costs. So I think that's good, and that's why we support it. One other comment. There was discussion about change in formulary, and Don mentioned, that there are adjustments to formularies throughout the year, and you would try to lower drug costs one way to lower drug costs is to go to different drugs. I've had a discussion with him regarding some information that's been very alarming to me regarding generic drug manufacturing from India and China. And the quality and the recalls have been quite high, and I'm looking into that further. But I just want to raise that as something to consider as you're, trying to find the lowest price generic. Most of the generics now come from overseas, and we have less control. FDA has less control over them. Thank you for your time.
Very good. Thank you very much. Seeing no other requests. Well, Mr. Fox, is there anyone else on the line? I'm sorry.
No, Mr. Chair, that concludes public comment on item 6A.
Very good. Thank you. Seeing no other requests to speak, the motion being before you, Ms. Hopper, please call the roll.
Margaret Brown?
Aye.
Henry Jones?
Aye.
David Miller?
An enthusiastic aye.
Irina Ortega?
Aye.
Ramon Rubalcava?
Aye.
Teresa Taylor?
Aye.
Shonda Wesley?
Aye.
Karen Greenross for Betty Yee?
Aye.
Mr. Chair, we have all ayes. Ramon Rubalcava making the motion, Margaret Brown seconding it.
Motion passes. Thank you very much. Thank you, Mr. Moulds. Brings us to agenda item 7A, risk mitigation strategies, HMO and PPO organization. Ms. Green.
Good morning, Mr. Chair and members of the committee. Marta Green, CalPERS team member. As you said, this is agenda item 7A, HMO and PPO risk mitigation strategies. This is an information item, and it is a continuation of our earlier conversations we've had regarding how risk fragmentation is creating significant issues within the CalPERS portfolio. During the January stakeholder forum, we spoke at length with our stakeholders regarding the challenges in the PPO basic portfolio. Then during the July offsite, we discussed the challenges the entire CalPERS basic portfolio is currently facing related to risk concentration, risk pool fragmentation, and adverse selection. Over the past couple months, we investigated a list of potential solutions and modeled preliminary premium impacts for the next few years under each scenario. Today, I'm very pleased to share our modeling results for those risk mitigation strategies, as well as a holistic overview of how implementing the different strategies would affect the portfolio of CalPERS basic health plans. Based on our discussion today and a stakeholder process to be completed over the next 2 months, we will bring final recommendations for your consideration and action in November. Next slide, please. So I'll start today with a brief refresher on the challenges our portfolio is currently facing related to risk concentration and our previous approaches to mitigating risk. Then we will show what the CalPERS portfolio will face if no action is taken to address risk. We have modeled what will happen to premiums and risk if no changes are made and no risk mitigation strategy is implemented. We have worked hard to model all possible risk mitigation interventions, and we will walk you through each. First, I will show you what a reinsurance or stop-loss approach would do to our portfolio. After that, we will get into various scenarios for plan eliminations or mergers and see how those would impact our program. Then we will review a portfolio rating approach, a concept that we first discussed in July. I will discuss 2 approaches to portfolio rating, one for the PPO and one for the HMO. As part of this section, I will highlight a few benefit design alternatives that could be considered for the PPO basic plans. Lastly, we will discuss next steps for the project. Next slide, please. As you recall, CalPERS ended risk adjustment in 2019 due to the complexity and lack of transparency with the prior risk adjustment model. Since then, the premiums for our basic health plans have no longer been priced upon the value of the benefit design and network, but rather on the concentration of healthy or unhealthy lives in them. As premiums in the high-risk plans increase, members in these plans were required to either assume a greater financial burden or leave their health plan. As a result, a few of our plans are in what's called a death spiral, a cycle in which premiums increase from one year to the next. Members then leave that plan because of those increases, and then the premiums consequently increase even more because risk is worse. As we mentioned in July, currently these plans are PERS Care, Anthem Traditional HMO, and Blue Shield Access Plus. And our projections indicate that HealthNet Smart Care is also on its way. I just want to pause here briefly to highlight how quickly adverse selection occurs. Risk adjustment was removed just 2 years ago, and 3 plans are already nearing unsustainability. Without mitigating the impact of risk concentration, health plans are forced to reduce their healthcare costs to remain competitive in our portfolio by introducing low-cost and narrow network alternatives to attract healthy risk, exiting high-cost areas, and/or removing high-cost and high-value providers from their networks. In short, plans are not currently competing on cost and quality, but instead on how they can attract members that use little or no healthcare. Because the HMO basic portfolio is experiencing similar issues due to risk concentration as the PPO basic portfolio, we combined our previously launched PPO assessment project with a larger effort to address risk concentration in the entire basic portfolio. At the July offsite, we discussed the need to address risk and the various approaches that could be considered. Today's presentation models the various options for consideration. Next slide, please. We looked at a variety of strategies to manage risk in our basic portfolio. The team analyzed historical member migration data and member responses to premium and provider network changes. Based on that study, the team modeled out premium projections for 2022 to 2026 for each scenario based on 2019 data. Projections factor in member migration among the plans and how the population risk changes in each plan over time. I should note, however, that there are no COVID-19 impacts assumptions included in the projections. This is because there is great uncertainty over the future cost impacts of COVID-19, and those uncertainties could potentially cloud the modeling. The goal of risk mitigation is to remove the risk component in the current premium rate so that members can enroll based on the true value of the health plans they choose. We will discuss what each scenario does and how it gets us closer to risk-neutral premiums. I also want to pause here to note that the projected premiums we are sharing today are solely for the purpose of our risk mitigation discussion, and they are not representative of final premiums, which will be aggressively negotiated by the CalPERS team and approved by the PHBC each summer. The modeling considers average annual healthcare unit cost increases, also known as healthcare inflation, in making its projections. There's a couple of caveats I want to share before we jump into the modeling. The first is that we are using the risk scoring tool that is currently embedded in our healthcare data warehouse for modeling. It is the same risk scoring tool that we use when we discuss rates with you in closed in April and an open session in June and the July offsite. As we discussed previously, we are looking at multiple tools to evaluate risk with the goal to use a transparent, widely adopted approach. We are in active conversations with our consultant actuaries, plans, and colleagues from other agencies and purchasers that mitigate risk to identify the best possible approach. When we bring this item to you in November, it will be with the best risk scoring tool for our portfolio. Secondly, I'm only showing you the larger plans in this presentation. Plans with small enrollment can have larger year-over-year risk score fluctuations, especially if the risk pool is as fragmented as ours is. The final modeling, which we will show in November, will include the smaller regional plans as well. With that being said, I'll dive into the modeling results. Next slide, please. So the first thing we modeled, or the first scenario here, is the status quo. If we don't manage risk within our portfolio, the basic plan premiums will continue to be impacted by adverse selection. As the healthier members migrate to lower cost options, the broad network plans retain a greater proportion of high cost members with more healthcare needs relative to other plans. While the differences in concentration of high and low health risk among the plans keeps increasing, the model shows an increasing disparity between premium and product values. So I'm going to start with these specific examples. The chart to the left shows the modeling results for basic PERS care. As a reminder, PERS Care is a broad network PPO plan with an actuarial value of 93%. This plan has the members with the highest medical needs among the entire basic portfolio. The pink bars represent the published premium for 2021 and the projected premiums from 2022 to 2026, which is pricing based on risk. The green bars represent the premiums for the plans priced based on the value of the product. Absent intervention, by 2026, the PERS Care premium is approximately 70% higher than its value. The chart to the right is basic PERS Select. PERS Select is a slightly narrower network PPO plan with an actuarial value of 86 to 88%, depending on how many of the VBID elements each member takes up, which means it has a slightly higher member out-of-pocket cost compared to PERS Care. The PERS Select premium is currently underpriced due to the concentration of healthy risk. Over time, the disparity between plan premium and value continues to widen. Next slide, please. In the HMO portfolio, we see the same patterns as in the PPO portfolio. The chart to the left is the premium projections for Anthem Select, which is a narrower network HMO plan compared to other plans offered by Anthem. Anthem Select is another plan that is currently underpriced due to its concentration of healthy risk. The model also shows that the projected risk-driven premiums are below the plan's value from 2022 to 2026. To the right is Anthem Traditional. Again, it has a broader network compared to Anthem Select and is offered in many high-cost, low-competition areas of our state. Opposite of Anthem Select, Anthem Traditional has a concentration of unhealthy risk. Like PERS Care, the high premium increases cause healthy lives to move out of the plan, triggering a death spiral. Next slide, please. To the left, we have Blue Shield Access Plus. When risk adjustment ended in 2019, Blue Shield Access Plus kept their premium rate relatively low by exiting the more costly Bay Area counties, and the board approved spending $99 million to buy down the rate in 2019. As one of the broad network HMO plans, Access Plus has a concentration of unhealthy members, which drives its premiums above the plan value. The disparity becomes even more prominent between 2022 to 2026. When Access Plus exited the Bay Area to cut costs, these high-cost members had to migrate to other plans, most notably HealthNet SmartCare. As we see in the chart on the right, we project that as soon as 2023, SmartCare's premium will exceed its value and the disparity will worsen into 2026 as healthy lives move out of the plan to avoid the higher premiums. Next slide, please. The next plan is Kaiser. As you know, Kaiser is the largest plan in our portfolio and has about 50% of our basic membership. As a result of its size, Kaiser's risk score is the median for the portfolio, and therefore its premium is defined as risk neutral. United Healthcare is currently underpriced relative to its value. Like PERS Select PPO and Anthem Select HMO, United Healthcare has also benefited by the concentration of healthy members. Next slide, please. So now I'm going to get into various alternatives. As we discussed in July, reinsurance is a risk mitigation tool typically used to protect an entire portfolio of products from outlier high-cost claims. The Affordable Care Act used reinsurance as a short-term risk mitigation strategy while the new individual market plans were launched. California and the Federal Exchange phased out reinsurance after 3 years. Different than a traditional reinsurance arrangement for this option, we use the principle of stop-loss reinsurance to model a premium adjustment. In this scenario, we modeled a $250,000 stop-loss point based on per member per year total healthcare costs in each plan. In the process, these large claim costs are taken out of the plan's experience and shared by all basic members. Therefore, a health plan with a concentration of healthy risk will have less of these large claims, but will share the cost of those claims with plans that have a concentration of unhealthy lives. The challenge with this methodology is it still incentivizes health plans to chase healthy risk and discourages plans to manage high-cost members since their claims no longer impact the premiums. To put it simply, if a plan member costs exceed $250,000, that member's costs are no longer the responsibility of the plan to manage. These are the individual cases that need the most care management, and this approach incentivizes the plans to focus elsewhere. Let me walk you through the model results in the next few slides. Next slide, please. So I'm going to walk you through some individual plans and how reinsurance would impact premiums. In general, some plans are partially benefited, and for others, reinsurance actually exacerbates the pricing issue, and some plans have some very strange results. This slide shows the modeling for reinsurance scenario for the 2 PPO plans. For PERS Care, the graph to the left, same as what we showed you in status quo, the pink bars are the risk-driven premium and the green bars are the premiums based on value. As you can see, the reinsurance premiums, which we're showing here in red, help reduce some of the risk in the premiums for PERS Care, but it doesn't get you to the true value of the plan, which is the green bar. PERS Select on the right will become problematic because the reinsurance pricing further reduces the cost in the out years and actually exacerbates the pricing relative to value problem. Each plan's enrollment has a unique cost distribution, and since the reinsurance approach concentrates only on mitigating the highest cost claims and not average risk, PERS Select actually over benefits from this approach. Next slide, please. Similarly, reinsurance does very little to address the risk-based pricing for Anthem Select. In the out years, reinsurance is actually projected to overcorrect the premium issues for Anthem Traditional, which would be problematic. Next slide, please. For Blue Shield Access Plus, reinsurance is, again, only a partial solution. And the healthcare smart care premiums are also overcorrected such that the premium is even further away from its value. Next slide, please. Next, I want to talk about an approach of merging plans or simply removing plans that are currently in a death spiral. We modeled 2 scenarios for the PPO. One is removing PERS Care, and the other is merging PERS Care and PERS Choice. For the HMO, we modeled a scenario of removing Anthem Traditional and Blue Shield Access Plus. I want to emphasize here that we would not actually recommend the removal of these plans from the portfolio for a couple of reasons. The first is it removes HMO options for members in several counties in California, as currently Anthem Traditional and/or Blue Shield Access Plus are the only HMO options in these counties. Even in counties offering other HMO options, removing these 2 plans causes significant member disruption in 10 other counties as it eliminates members' access to some of the major provider groups that are not in the network for other HMOs. So I would not recommend this on a policy basis, but we wanted to show you that we thought through every potential option to address risk. In the next few slides, I'll walk you through the scenarios and show you what the projected premiums would look like in the next few years. Next slide, please. First, we modeled the scenario of removing PERS Care in 2022. The chart to the left illustrates the projected premiums for this scenario. After removing PERS Care, the PERS Choice premium increased by about 13% in 2022, mainly driven by the addition of the high-risk members from PERS Care. After that, PERS Choice enters into the beginning of a death spiral, and its premiums quickly catch up to the PERS Care level in a few years. At the same time, PERS Select premiums remain low and underpriced due to its concentration of healthy risk. To the right, we modeled a scenario in which we'd create a new plan with a merged benefit design somewhere between PERS Care and PERS Choice. For the sake of modeling, we called it PERS Health. Very similar to removing PERS Care, the projected premiums for this PERS Health plan become unaffordable in a few years as the new plan quickly enters into a death spiral. Next slide, please. This next slide shows the projected premiums for PERS Choice or PERS Health, because they'll be about the same, and PERS Select compared to its plan value under the scenario of removing PERS Care or merging PERS Care and PERS Choice. Since premiums are priced based on the underlying health risk of the plan, PERS Choice plan premiums or PERS Health plan premiums are now above the plan value, and this disparity gradually increases over time as healthier members move out of the plan to lower cost options. And PERS Select premiums continue to be lower than its value due to the concentration of healthy risk. Next slide, please. The next option we modeled is eliminating Anthem Traditional and Blue Shield Access Plus. These are two broad network HMO products. Again, I would not recommend this approach for the reasons I outlined earlier. If we remove Anthem Traditional and Blue Shield Access Plus, the chart to the left shows the projected premiums for Anthem Select, with the pink bars, the risk-driven premium, and the green bars, the pricing based on value. This chart shows that removing two broad network plans still won't close the gap. To the right is Health Net Smart Care. The premiums continue to escalate and eventually exceed the value of the product. So in sum, the modeling shows that merging plans or eliminating plans would not move the remaining plan premiums closer to plan value. It would simply remove one death spiral and push risk around in the portfolio to other health plans and eventually cause those plans to enter a death spiral. Next slide, please. We've just spent some time talking about a variety of interventions that do not address the underlying issue of adverse selection and risk pool fragmentation. Now I want to spend some time talking about portfolio rating, the concept I introduced back in July. Portfolio rating is designed to address the fundamental cause of our portfolio instability while also ensuring our plans are priced on their value and our carriers are incentivized to manage the health of our members. I'm going to walk through the modeling of portfolio rating on the PPO, including scenarios for implementing portfolio rating in 2022, as well as an option for 2-year phase-in to ease premium changes. We will also show you some benefit design alternatives under portfolio rating, including changing the PERS Select benefits to mirror Covered California's Silver 70 plan, as well as a 2-plan model we are calling for this conversation PERS Platinum and PERS Gold. I will then walk you through the portfolio rating of the HMO. Next slide, please. So the ultimate goal of portfolio rating is to have the carriers in our portfolio compete based on the value of their products instead of chasing healthy lives. Under portfolio rating, we have different approaches to achieve value-based pricing for the HMO and the PPO. On the PPO side, we can price each plan based on the network and benefit differentials, while for the HMO, we have to utilize a risk adjuster tool to remove the underlying health risk from the pricing. This has to do with what's common among the PPO plans that is not shared among the HMO plans. Starting with the PPO, all of our PPO plans are administered by a single third-party administrator, in our case, Anthem Blue Cross, with the same business model, the same care management tools and approaches, the same underlying provider contracting, the same leverage and provider negotiations, and the same geographic footprint, which is the entire state. Different among PERS Care, PERS Choice, and PERS Select products are the provider network and benefit designs, such as deductible and coinsurance. All of these have financial values associated with them. Therefore, we can pool the entire PPO basic population together and treat them as one health plan with tiers, then price the PPO tiers based on the network and benefit differentials between the plans. The situation on the HMO side is more complex. Other than the same benefit design, we have a number of carriers within our HMO, and each one of them have different business models. Their approach to care management is different. The nature of the contracts are different in terms of their penetration of capitation or fee-for-service arrangements, how much leverage and influence a carrier has in a particular geographic location, as well as the varying geographic coverage and provider networks. From a pricing perspective, it is impossible to have a standard way to measure each piece and individually turn them into a value. Therefore, on the HMO side, we have to remove risk from the pricing as opposed to price basing on the network and benefit designs like we can on the PPO. As I mentioned in July, we discussed the HHS HCC risk adjuster tool, which is used to risk adjust the state and federal exchanges. But we are also considering other tools that meet our needs, are transparent, and are widely adopted. We are working on identifying and refining the risk score methodology that is appropriate for the CalPERS population. We used the MARA, M-A-R-A, risk score methodology in the modeling for today's discussion, as it is readily available in our data warehouse and is the risk scoring tool we use during the rate setting process. While we're focusing on the HHS HCC risk scoring tool, which will provide greater transparency and is, as I said, is used by the state and federal exchanges, we expect very similar direction and relative magnitude for modeling purposes as we see with the MARA risk scoring tool. Next slide. I'm going to start naming the slides. This is slide 19, so those that are on the phone can follow along. So again, slide 19. So let's start on the PPO. In this scenario, we show that if we portfolio rate and price the products based on value starting in 2022, there is a significant change in the first year, then premiums become much less volatile than they have been in recent years. This chart shows the 2021 risk-driven premiums for the 3 PPO plans, and then premiums for 2022 through 2026 priced based on the plan's value. Under portfolio rating, all 3 PPOs have stable premium increases year over year as member migration between the PPO plans are no longer impacting the premiums. However, there are significant premium changes in the first year of implementing portfolio rating. PERS Care premium decreases by about 18% from 2021 to 2022, and PERS Select premium increases by about 43%. Also, I'll get more into this in a moment. You will see that there's very little difference in the value between these 3 products. Next slide, slide 20, please. This is what it would look like if we phased in portfolio rating over 2 years. As I just mentioned in the previous slide, we projected significant premium change in 2022 for PERS Care and PERS Select under portfolio rating. In this scenario, the impact would be spread over 2 years, 2022 and 2023. Here you can see a more gradual progression towards the risk-neutral premium. Another thing we can consider is to buy down the PERS Select premium in 2022 using surplus in our healthcare fund. So you will have PERS Care and PERS Choice to get to the risk-neutral pricing in the first year, and PERS Select would go halfway in 2022 and then reach risk-neutral pricing in 2023. Next slide, slide 21, please. The next benefit alternative for PERS Select under portfolio rating. What we did here is we mirrored the covered California Silver 70 product with 70% actuarial value. What that means is the plan is paying approximately 70% of the average healthcare cost for members, and members are responsible for 30% of the costs. I'm going to pause here to say that Covered California's benefit design is a high deductible health plan. This product is not consistent with CalPERS' approach to comprehensive health coverage, and we will not be recommending this approach in November. However, we felt it important to show that it is possible to create a low premium product, understanding that cost sharing would be very significant. On the graph, we have the purple bars representing the premium projections for the PERS Care Silver 70 product, and the orange and green are PERS Care and PERS Choice. Once again, this shows that PERS Care and PERS Choice premiums and benefits are so similar when these products are priced based on their value. Offering 2 products with very similar benefit designs provides little meaningful choice to CalPERS members. With that in mind, the team came up with alternatives to consider. Next slide, slide 22, please.
Marta, before you move on, I have a question.
Absolutely.
Mr. Jones? You're muted.
I could wait till she finishes. It's a general question, so I could wait till she finishes.
Very good, thank you. Continue on, Ms. Green.
Thank you, Mr. Chair. Okay, here we are on slide 22. This chart models replacing the current PERS PPO products with 2 new products for which this presentation we're calling PERS Platinum and PERS Gold. These placeholder names reflect the actuarial value middle tiers used in the state and federal exchanges. With a PPO lineup like this, we would have products that would have a true distinction between their designs. What you see on this chart is PERS Platinum, a PPO plan with a 90% actuarial value, and PERS Gold, a PPO plan with an 80% actuarial value. Currently, PERS Care is approximately 93% actuarial value, and PERS Choice is at an 88% actuarial value. And again, as I mentioned previously, PERS Select is between 86 and 88, depending on how many elements of the VBID design elements a member takes up. So the PERS Platinum with 90% actuarial value is in between PERS Care and PERS Choice. Again, 90% actuarial value means the plan is responsible for paying 90% of the anticipated healthcare costs, and the member is responsible for 10% of the costs. It is a very rich benefit design compared to other commercial products offered in the market. And then we have PERS Gold with an 80% actuarial value, which with slightly higher out-of-pocket costs than PERS Select. The projected premium is slightly higher compared to the current Select product, but you will see that it will remain over time a very competitive product within the portfolio. Although these actuarial values for PERS Platinum and PERS Gold would be slightly different than Care, Choice, and Select, by working closely with our stakeholders and their preferences and priorities, we can ensure that the benefit designs feel similar to the original product lineup. With these two products, we would have a true distinction in benefit and pricing under portfolio rating of the PPO. We can achieve these actuarial values through a variety of different benefit design options, including various deductible and out-of-pocket cost options, and the choice of in and out-of-network benefit coverage. The team is currently working on the various benefit design options, and we will engage stakeholders in their preferences over the next 2 months. Then we can bring options for consideration at the November PHBC. Next slide, slide 23, please. So between now and November for the PPO, we will have a multi-phase stakeholder process. We will model different Platinum 90-10 and Gold 80-20 benefit designs, including network and cost-sharing alternatives. We're going to listen to our stakeholders and incorporate their preferences. And our final design options will be presented in November for a decision that would be incorporated in the 2022 rate development cycle. Next slide, slide 24, please. Next, I'm going to talk about the HMO. First, I want to step back and provide a global look at what HMO pricing is doing right now and what it would do under an HMO portfolio rating environment. At the chart on the left, you see premium projections in a line graph if we do nothing to mitigate risk. As you can see, we have different products on very different trajectories due to risk concentration. The steeper the line means they're getting more unhealthy lives. The most obvious is the red line of the top, which is Anthem Traditional, which, as I said, is in a death spiral. The chart to the right shows premiums in a portfolio rated environment with less volatility and lower year-over-year rate increases. Also, the difference between the lines reflects the value of the product regardless of the risk concentration in the plan. In the next few slides, we'll walk through the scenarios on an individual plan basis. Next slide, slide 25, please. First, just as a reminder that this modeling is based on the MARA risk score tool, which is currently embedded in our data warehouse. We are still working towards identifying and refining the risk score methodology that is appropriate for CalPERS. As I mentioned earlier, we are considering the HHS HCC risk scoring model and other alternatives that meet our objectives. As a result, these premium projections are not final, however, they're directionally correct. You may see small movements in these projected premiums in November when we use a final risk score tool in our model. But back to the graph. Here's what will happen to Anthem Select and Anthem Traditional under portfolio rating. Anthem Select is currently benefited by the concentration of healthy members, therefore its pricing will go up when it's reflecting the value of the product. Anthem Traditional, with its concentration of unhealthy lives, is the opposite. The premium will go down to reflect its true value once it's no longer in a death spiral. Next slide, slide 26, please. Next is Blue Shield Access Plus, which is in a similar situation, albeit not as advanced as Anthem Traditional. It is currently overpriced due to its concentration of unhealthy risks, so the premiums would go down with a move to portfolio rating. HealthNet Smart Care will likely see a slightly more than normal premium increase in the first year, then level off in the out years as we prevent it from entering a death spiral. Next slide, slide 27, please. For Kaiser, with 50% of our basic membership, the risk score wouldn't change if we portfolio rate. The projected premiums for Kaiser are based on the estimated unit cost increases or healthcare inflation that we've seen trending in the healthcare market. United Healthcare would see a premium increase in the first year unless the plan improves efficiency or makes other changes within the product to bring down the premium. After the first year, the plan will level off to a modest trend. Next slide, slide 28, please. For next steps, so if we are going to proceed with portfolio rating in the HMO, we would need to select the risk adjustment tool. As I said, our priority is to select a transparent and known model. We are still focusing on HHS HCC, but we'll consider other tools as appropriate. We will then have to calibrate and normalize to the CalPERS population as necessary. We will also need to take a look at any year-over-year volatility in the risk scores in the regional and small plan offerings and determine if any adjustments need to be made based on plan size. We then need to go through a process of validating the risk scores with our carriers to make sure our risk scores reflect their data regarding the population in their plan. Beginning with the stakeholder engagement briefing last week, we will be discussing our approach with our stakeholders over the coming months to get their feedback. We will meet with representatives from each of our distinct stakeholder communities, including employers, labor groups, retirees, and plans. I truly only have two goals between now and November: refining our approach and methodology with the plans and spending as much time as possible understanding the needs and desires of our stakeholders. Then we will present a final risk mitigation strategy package and modeling in November. The last thing I'd like to reiterate here is that if we don't mitigate risk concentration in our portfolio, two things will happen. The first is that we will continue to experience large member migration patterns and death spirals in our various plan offerings. We are now only 2 years out from removing risk adjustment, and we already had 2 HMOs and 1 PPO in a death spiral. Without truly mitigating the underlying risk concentration, the best we can do is close plan offerings, which will just move the death spirals to other offerings. This volatility puts the sustainability of our program at risk. The second thing that will continue to happen without risk mitigation is that plans will continue to compete on attracting healthy lives as opposed to competing on costs and quality of care. Right now, the primary way to reduce premiums for individual plans is to have more healthy lives or by cutting out the high-cost, high-value providers. This is in stark contrast to our goals of having health plans do a better job negotiating with providers to bring down costs and to improve the quality of the care they are providing to our members, regardless of their health conditions. We will not be able to achieve these goals without a comprehensive risk mitigation strategy. Next slide, which is the last slide, slide 29. So our overall next steps are to have our robust stakeholder engagement process, refine the portfolio rating methodology for both HMO and PPO, determining any changes in benefit designs that we would recommend, and bringing the final methodology and team's recommendations for board discussion and approval in November. And with that, that concludes my presentation. I'm happy to take questions.
Thank you, Ms. Green. Thank you for the presentation. We certainly want to make sure that our plans are viable. So this is a good discussion to have. But even more importantly, we want to have the least amount of impact to our members that we can. So being able to work this out, I think, is a great job on your behalf and as well as your staff. So thank you. I have a couple of questions. Mr. Jones.
Yeah, thank you, Mr. Chair. Again, Ms. Green, thank you for an excellent presentation. As usual, it's clear and easy to follow, and very informative. I have a couple questions. One is that you made reference to the reserves to buy down the premiums in 2021 early on. So my question is whether or not that had been removed from your projections going forward, since we have no way to determine whether or not there will be additional funds to buy down premiums going forward. And the next question is that looking at this overall health plan, I mean, I've been on the board now 12 years, and I've seen significant changes where we've removed risk adjustment, we've put it back. I've seen the elimination of plans and expansion of plans. How do we come to grips with these to avoid these frequent major changes in our health plan strategies? Because if our ultimate goal is to make sure that our members are getting healthier and the cost is affordable, how do we evaluate if every 2 or 3 years we're changing some significant components of these plans so you can't get a handle on what's working and what isn't working? So that's a concern I have in terms of going forward. And I know you mentioned that you're not recommending eliminating any plans, but I mean, it's part of that discussion. So I'd like to hear your views on those issues.
Absolutely. Thank you for both of those questions. So the first question, remind me, so we talked about the elimination of plans. The first question, remind me, Mr. Jones, was?
The buy down reserve.
The buy down. Thank you. Sorry. I was paying so much attention to this issue, which I find to be very intriguing that I forgot the first question. So on the first question, so we modeled just 1 year of buy downs because we have some sense of where we may be with respect to reserves for the 2022 plan year, but we cannot project where we would be in 2023 and beyond. So for that projection, we simply looked at 2022. I cannot guarantee that we would have enough reserves to do the buy down that we modeled. I think it is reasonable to think that we would have that much reserves, but a lot of whether or not we would have it has to do with COVID and how many costs we see relative to COVID and whether or not we've got a lot of treatment costs and or vaccine related costs that would make that buy down not tenable. But as of right now, I think it's reasonable to assume we would have some reserves available for a buy down in 2022 for PERS Select, which is specifically what we modeled. For your second question, I agree that the volatility in the portfolio is a big problem. And I think that we've tried over time a number of different strategies to mitigate risk. And so closing the plans or trying to consolidate into single plans as we've modeled here is a way that some organizations manage risk without doing portfolio rating. The problem with a portfolio as big as ours and as diverse as ours is to really do that well, you have to go down to a single plan. And that excludes our regional offerings. That excludes a lot of things that are high performing and are positive for our portfolio. And so we could continue to do that, but it's again going to just move that risk around to other products. And then we will have to collapse those products. And I think it's disruptive for our members, as you mentioned, and it also just doesn't, at the end of the day, get to the underlying issue of pricing everything relative to its value or relative to risk neutral pricing. The prior risk adjustment strategy, as I mentioned, had a number of issues relative to transparency. It was complicated. It had 4 phases with true-up that created unexpected results. By doing portfolio rating, you don't have those complications. You don't have those issues that could create the failure of the program. What we're proposing here is very similar to what the state of Washington does and other major purchasers, where they simply rate on the front end a risk neutral premium as opposed to attempting to do a lot of risk transfer payments on the back end. Does that address that question?
Yes, it does. So what's the solution then?
So I believe that the solution is portfolio rating, and then, as you said, stability, so that we can come to a specific, neutral, stable platform. We allow members to settle into their plans, and we monitor the risk concentration and member migration patterns from there. Does that mean that we never recommend a change in the future? No, but I think it's a much more stable platform than the one we have today.
Okay, thank you. And that may go to the discussion going forward, is to have a discussion about a no change policy for 4 to 5 years and see what the results may offer, or have a sunset clause or something like that.
At least a lot less change than we've been seeing.
Right. Okay, thank you very much.
I'll also add just that, there are a lot of other large purchasers. This is the norm in the market. The large purchasers like Medicare, Covered California have been doing this for years and without really any drama. I think we made it more complicated by doing it in-house in a less transparent way and ran into difficulties there. But once we get this, it becomes something that's knowable to the plans that they can factor into their pricing decisions on an annual basis, and that we can make the adjustments. And the goal here is to increase stability, not to add instability.
Okay, thank you.
Very good, thank you. I have Ms. Taylor.
Thank you, Mr. Chair. So I have a couple of questions. You answered one of my questions, which is what's the difference between risk adjusting and portfolio rating? So I did get that answered. Thank you very much. Mara risk scoring, which is the tool we use, and that's developed by us, I take it.
No, it's not developed by us. It's just naturally embedded in our data warehouse. And so there are, that I'm aware of, at least 6 or 7 well-known risk adjusting tools or risk scoring tools. Mara is the one that's currently embedded in the data warehouse. It is a well-known tool, but isn't typically used for the purposes of portfolio rating. So that's why we're looking at the HHS HCC model as a risk scoring tool again, but we're focused on that model, but that isn't guaranteed that that will be the best model for our population.
And how do you determine what's the best model?
There's a lot of different analysis we're doing. One of the things that we do is we look at the risk score outputs and compare it to claims experience. So if you can look on an average per member per month basis, how much we are spending per person per member, and seeing how that correlates with the risk score, they should be longitudinally correct, right? So plans with higher risk generally should see higher than average claims and encounters, right? Because some of them are embedded in the capitation. And plans with lower risk scores should see lower. So you should be able to see the claims volume migrating on the same pattern as the risk score. So that's one. We also look at pharmacy claims. So how do pharmacy claims relate to the risk score? Because in general, people with greater health conditions or comorbidities have more pharmacy claims associated with them. So you should see alignment amongst the various things we can measure relative to our members' health to the risk score, and find the one that most closely matches all of those ways in which we can measure our own members' health status through their claims data.
And how long do you think it would take for us to determine which one fits our population the best?
My goal is to have that determined in the next 30 days.
Oh, wow. Okay, that's pretty fast.
We've been working on this since July. So we've done a fair amount of modeling. We've looked at year over year. We've looked at MARA risk score outputs. We've looked at pharmacy-only risk score outfits. And so we're further along than I think my presentation, which I had to finish 2 weeks ago. Then really was drafted in this presentation. And we're still feeling really good about the HCC model, but we want to be absolutely certain before we put forward a recommendation.
Now, I guess one of my other questions is, as we go through this, are we, like, so we've got the portfolio rating, we've got the PPO process that we're going to go through, right? Which is a few steps here, the 90-10 and the 80-20, just and trying that out and talking to stakeholders. And that's with a 2-year phase-in, right?
The portfolio rating with the 90-10 and the 80-20, I did not model with a 2-year phase-in because they would be new products. It would be really difficult to phase that in because it would have all new membership. So if we were with the existing products, it'd be much easier to do a 2-year phase-in because you already have a known population in each product and you're just adjusting for the people that move. But with 2 new products, we would not necessarily be recommending a 2-year phase-in on the PPO. But if we stay with the current lineup, the PERS Care, PERS Choice, and PERS Select, a 2-year phase-in could be a recommendation.
Okay, and then, and so as you roll this out to the stakeholders, do you foresee a problem with going to the 2 programs rather than the 3? Do you think that that's going to cause some contention with our stakeholders? And does it reduce, and here's a concern of mine, one other question. Does it reduce the ability of our rural folks to be able to access healthcare?
That's an excellent question. So I'm going to take that one first, and I'm going to go back to how we're managing the stakeholder. I actually think it improves choice for the rural membership because right now, if you want a broad network plan with a rich benefit design, your only option is PERS Care. And as I've modeled here, PERS Care is incredibly expensive in compared to its value. So going to a portfolio rating or risk neutral, a PERS Platinum and PERS Gold model would reduce costs for those rural members that would still have access to that broad network PPO, that PERS Platinum product. And as I said, we can actually calibrate each piece of the benefit design to get as close to the existing products as possible, meaning try to tailor the cost sharing to as close as possible. There will be some differences because PERS Care is 93%. So if we're going to compare PERS Care to PERS Platinum, PERS Care is 93%, PERS Platinum is 90%. There will be a little bit of change, but we can try to get as close as possible. So from a member experience standpoint, it feels a lot like PERS Care. With PERS Select, it's a little bit different. So I think the reason that we are modeling the 80-20 benefit design, as I said in the presentation, so there's a real difference between the two products because the other plans are so similar that there's not a whole lot of difference or real choice. But also we've heard from our employer stakeholder community that it's very important to have a lower premium PPO product for some of their members, especially in the areas that don't have HMO offerings. And so this is going to create a product that is going to look a lot like PERS Select with a slightly higher premium once it's based on values. So we hope that that meets the needs of our employer community as well. So that's why we want to meet with each of the distinct communities and ensure that what we're proposing to you is the best lineup that we can that solves as many of their needs as possible.
Well, this is a big undertaking. I really appreciate you working so hard to get everything under control. I know it's not going to control our medical costs, but to the degree that we can help our members afford this, I really appreciate the work you guys are doing. Thank you.
Well, and I believe that the stable portfolio will give us greater opportunity to actually do meaningful work on healthcare costs because we will no longer be having health plans chasing healthy lives, but instead will be truly incentivized to manage per unit costs. And so that's where the competition study and some of our other important work comes in. And I think this portfolio is the right platform to implement some of those solutions as well.
Well, I appreciate that, man. And I get Henry's point on change, and certainly I've only been here since 2014. I don't remember now. But I've seen a lot of change, and I remember asking the questions of why we were dropping the risk adjustment. I didn't realize it lacked transparency and that it really wasn't based on normal risk adjustments that are done.
I've heard from many of our carriers as I came on board that, they would have risk scores that would come out the other end they didn't understand. They didn't understand, didn't seem to track with their data, and then they would have unexpected results. And so we have been meeting with our carriers both as a group as well as individually, and we have committed to them that we would be providing transparency to what the risk score looks like. We'd be validating it with the carriers so there would not be any unexpected results.
Awesome. Again, thank you very much for the work.
Thank you.
Thank you. Ms. Middleton.
Thank you, Mr. Chair. And first, I want to thank Marta and all of her team and Don for an incredible amount of work. I am just wonderfully impressed with what you have done. It's a very small thing, but a rich compliment for the name change to PERS Platinum and PERS Gold as a 36-year member who has had to check the difference between Select Care and I don't know how many times to figure out which one was the better program. I think I actually will understand Platinum.
Well, thank you so much. It is a placeholder name, and it's the pleasure of the board if that's what you choose to adopt. But I think it is clear and transparent what those products are if you name them by their metal tiers.
Thank you.
Totally agree. Thank you, Ms. Middleton. Ms. Brown.
Thank you, Mr. Chair. I do agree with Ms. Middleton. I'm always looking up the difference between the different PERS Care, PERS Select. Marta, I want to make sure I understand what we're sort of recommending. I think it's page 22 of 29. I mean, we're not recommending, it's just a discussion. Going to the portfolio rating PERS Platinum and PERS Gold. Is that correct, what we're aiming at?
Yeah, so
recommending we aim for, correct?
What I would like to bring to you in November is a portfolio rating approach that has an HMO element and a PPO element. And that on the PPO side, I would like to model and present to you for consideration a new product lineup that has distinction between the products. So that's the PERS Platinum and PERS Gold. So it's a little bit of a two-phaser, right? So the first piece of it is the portfolio rating piece, which has two elements, right? HMO and PPO, and then also potentially a new lineup within the PPO. We don't have to do both. we could simply do portfolio rating and leave the PPO as it is. I believe that the two plan lineup will make more sense in a environment.
Great. And then we would still have 90-10 and an 80-20, right? The gold is 80-20, the platinum is 90-10. Okay, good.
Yep.
So you talk about calibrate to make it feel the same. And so just give me some ideas of what you think about in terms of calibration.
Okay, so when I talked about calibration, a lot of that is taking the risk adjustment tool and ensuring that so HCC in the risk adjustment tool that we're focusing on stands for healthcare condition. And what it does is it scores different healthcare conditions based on the claims that are fed into it. And so there are times at which some healthcare conditions are more prevalent in one population versus another. And so we need to make sure that, and this is part of the normalization process, so thinking about our risk scores versus what the plan's claim experience, some of that modeling I was talking about just a few questions ago, that calibration is, do we have to change the weighting between any of the any of the healthcare conditions because they're more or less prevalent within our population than they are on, say, the federal exchange? My desire is to not have to do that, not have to change any of the weighting, but we have to see the full results and make sure that everything makes sense before we determine whether or not any calibration of the HCC model is required. But I think your question was more designed towards the benefit design structure and how we can make the benefit designs feel to the member more like the benefit designs in their existing products. So the PERS Care, PERS Choice, and PERS Select. So the way in which we do that is you have a whole menu of different options you can use to get to a 90% or an 80% actuarial value. There are choices like, is your copay X or Y, $10 or $20, $20 or $40? Is it a coinsurance? Is it 10%, 20%, 15%? What are those different amounts? What does the out-of-network benefit look like? Do you have a limited out-of-network benefit? Do you not have an out-of-network benefit? All of those things roll up into an actuarial value to get you to the 90-10 and so or the 80-20. So the point of the stakeholder process is to maybe model 4 different options or 10 different options for each product, so the 90-10 and the 80-20, and try to get one of them as close to the existing PERS Care, PERS Choice product design for the 90-10 and the PERS Select product design for the 80-20, and see if there's any preferences that the stakeholder community has for a little bit more here, a little bit less there, a little bit more generous, a little bit less generous based on their desires for their healthcare product. And then we can bring a 90-10 and 80-20 product to the committee for consideration that reflects the stakeholder desires and is as close to the existing product lineup as possible. Does that help?
It does, because I had, when you said calibrate, but I had also wrote coinsurance copay. So it's the same thing. And again, I remember, I think I was just on the board when we increased the copays, and it was a very unhappy time for our members. And so I don't think they're going to be happy, but especially with our lower cost PPO going up, it looks like 527 to maybe 606 under this current what you're looking at.
It would be
and that's a big jump already. But I do appreciate this, and we'll look to see what the stakeholders will say. Thank you.
Thank you.
Thank you. Mr. Rubalcaba.
Thank you, Mr. Chair. Thank you, Don. Thank you, Martha. This is amazing. I just want to start. I have a couple of questions, but I want to start by framing I think our committee chair started correctly. We want viable plans, but we also want to be mindful of the impact on the members. And so I'll start with the second part first, the members. One thing that always seems to go counter to our best plan designs, our best science, whatever, is that not everybody plays with those rules. There's so many there's a hospital, there's the insurance company, the medical groups, and they have conflicting districts. And I'm worried about the members who sometimes I like what you said, that they shouldn't be trying to chase the best risk, and they should try to have I mean, they're in this business, not to, I mean, the medical groups are in the business to try to take care of members. And that's what I want to see, that there's an incentive for outcomes, that if that they have chronic illness, we should treat that chronic illness. If they're pre-diabetic, they should keep them, make sure that they're going to the diabetic stage. And that's what I want to make sure that we have incentives. And sometimes I think we don't allow that to happen because so that's my concern, is that there's always going to be people who are going to try to game the system. For example, I'm worried about our members really have loyalty to their doctors, but sometimes they're not sure or they don't know whether that doctor has the best clinical practices. Are they maintaining them? Are they improving their health? Are they trying to improve their health? And it's and that's something I wish we had a way to gauge. And so that goes to my first question. I was going to start with the member impact, but let me go to this whole thing. I know that at least what I read about this science about this, that these quality networks are designed because they have proven medical groups that can focus on, I hate the word managed care, but they focus on making sure that they engage with the members and they're taking their numbers and they're improving those numbers, medical groups. So where is there a role for those? Can you explain to me how this profile rating, how would that impact with the plan design when some groups may have more than one ACO or they have different quality networks and their contracting is all over the place. There's, there are variants between fee for service versus compensated. Thanks.
Yeah.
Yes. That way. How do we deal with that? That's the first question. Then I have two more. Thank you.
So I'll start.
Sorry for all the preamble. Sorry.
No, you're fine. Absolutely great. So I'll start with the quality of care that is provided to the members. This is the managing of the chronic conditions. This is ensuring that members remain healthy throughout the course of their lives. And so in addition to incentivizing with pricing to be aligned with care management, which is what portfolio rating does, the other thing that we do have and we're continuing to improve on is the performance measurement in our contracts. And so we have a variety of things that we measure health plan performance, and a percentage of their administrative service fee is at risk based on their performance against those measurements. And we're focused on some of the key chronic conditions, including diabetes that you mentioned, as a measurement of performance. And so all of our health plans are currently required to be active participants in their members' care management, some to more effect than to others. But the complication of the existing scenario is on top of that. So, they have to do it or they can lose some administrative services fees, which is true. But then also they're advantaged in the market, in the CalPERS market, by getting rid of some of those lives, which is not what we want them to do. So what we want them to do is be incentivized to keep those lives and manage the care. So their members are taken care of, but also so that they perform well against their performance measurement. So I'll just pause to say that I don't think that our existing performance measurement scheme, although it's robust, it is not perfect. And we are thinking about ways that we can align those performance measurement with other major public purchasers like the Department of Healthcare Services, which purchases on behalf of Medi-Cal, and Cover California. Because if you think about if we all pooled our resources together, so the 13 million in Medi-Cal, the 1.5 in Covered, and our 1.5 all together, that's a lot of Californians that are pushing the health plans all in the same direction. So we think that we can do some pretty cool stuff by aligning on certain measurement tools. But to your second question, I think it's actually a great question, the ACO question. So that's what TRIO is, as an example. TRIO is an accountable care organization product, and it was developed and designed to do specifically the thing that you are talking about, which is really pushing a lot of the care management responsibility to the high-functioning medical groups that need to coordinate closely with their members to help them manage their chronic conditions. And that we want to encourage those in the network, but we don't want to encourage those in the network just for the purpose of attracting healthy lives that don't need that care management. We want those in the network to actually also deal with the chronic conditions. And so part of that is this risk neutral pricing So when members make their selection, they pick the product that best meets their needs as opposed to just the one that's either cheaper or maybe because their employer covers 100%, they just pick the expensive one because they think it's the best when it's not actually priced on its value. So I'm hoping over time that we will see more of our carriers integrate accountable care organization type contracting models within their existing arrangements.
Thank you. And my second question relates to the second answer. Thank you for those excellent answers for performance measurements. I knew that. Thank you. Forgot. Mercer helped you do the new mitigation strategy, but they were also doing some study, or you guys were working on some sort of what is the right mix. Is this part of that study, or is that a separate study that we're still expecting?
That's the competition study, which we will
competition study, right?
And that's with not with Mercer, but that's with Bates White, and it includes Lemore Daphne, the professor from Harvard,
that's
that saw the July offsite.
And where's that at? The competition study?
We will have. I'm hoping to have some preliminary information by November, but we will have full results by the end of the year.
Thank you. And my last question is: a lot of my colleagues talked about the impact on the stakeholders. And I'm glad you're going to engage with them and what have you. But I think one thing that would be helpful for them to understand is you mentioned a lot how death spiral and people basically vote with their feet. They walk to the people who are sick, stay with the doctor. The people who are healthy walk. It would be helpful, I think, if you share the enrollment numbers and see so they can see the trends, how they have changed. Because you mentioned it, how some plants are impacted because they leave an area and other people had to pick them up. But if you could show the numbers, I think that would be helpful. I mean, like what are the current, and who's growing at the expense of what, for example. I think that would be helpful, I think.
Absolutely. We can show enrollment over time. That's an easy add. And what we will intend to do is a shorter version of this presentation to begin those conversations. And we can include all of the enrollment information as you suggest. And then we'll talk about different benefit design alternatives and get their feedback.
Thank you for doing that. And again, I compliment you on all the work you guys are doing. Don, you have a good shop there. Thank you, Martha. Appreciate it.
Thank you.
Thank you, Mr. Chair.
Thank you. Ms. Oliveris.
Thank you, Mr. Chair. Ms. Green, would it be possible to get a list of the chronic conditions that outcomes are managed for?
In the performance guarantees in the contract?
Yes.
Yeah, I can send that. I can get that to you. I don't have it off the top of my head, but I can.
How do we ensure equity when it comes to looking at chronic conditions? So chronic conditions can vary by race and gender.
Yeah, that's an excellent question. So I think we've discussed here in this committee, but I welcome Don to jump in, that CalPERS does not currently collect race and ethnicity data. And that is a project that we're undertaking. So race, ethnicity, gender identity. So we're the full, what they call the SOGI information. We are going to start to collect that. And then we are going to design performance incentives that are specific to the disparities in healthcare delivery by those different categories that we do not currently do. So currently health plans only are reporting on the aggregate, irrespective of race, ethnicity, gender identity, except for those conditions, of course, that only impact one gender. But in some, they're not differentiating between the different categories, but it is a strong goal of mine personally, as well as the health team broadly, to be able to measure those on all of those important elements, because we all know that health outcomes vary distinctly on those categories.
Yeah.
What's the approximate?
Sorry, go ahead.
What's the approximate timeline on that?
So let me back up for 1 second. So we don't collect the race and ethnicity data in CalPERS. We collect it. We've started collecting it in our surveys, but we have not been stratifying it, which means that we haven't been using it and essentially using the data to look at any discrepancies in quality or access and so forth. So we're going to be collecting it across the board so that we can know the difference between the experience with respects to grievances and outcomes of those grievances on the CalPERS side, and then we're going to be stratifying it in our survey, so we'll have a better sense of everything from access to outcomes. The technical work that's going on the CalPERS side is going on now, and we expect it to be completed in January. So there's quite a lot of programming that goes into this. The initial timeline was out well into the spring. We've pushed it, working with our IT folks, back to as soon as we can. The stratification work on the surveys is going to begin with the next survey that comes in, which is the 2021 survey, and I think that comes in the fall. Dr. Logan is, I know, available if I've messed up that date, but I think that's right. But so the other thing that I'll add we've been doing, this is something that as I think you know, enterprise-wide has been a priority, is we've been out talking with Medi-Cal, and particularly with Covered California, about what they do and other initiatives that we can undertake together to make a difference in this space. It is the entire health leadership team. This is something that is a top priority for us. It's something where we feel like we really want to make a difference. And frankly, we do not have, right now, we haven't historically had the picture into any disparities that exist. And knowing what we know about the healthcare system in the United States, it's likely that some of those exist in our membership as well. The first step is really understanding and getting a clearer picture of what's going on here. The next step are initiatives.
Thank you. So that's the output process, right, in terms of collecting that data on any disparities. But on the input, how do we select our current list of chronic conditions?
Oh, for performance measurement?
Yes.
So we look at a couple of things, just literature on what are the chronic conditions that most impact members' well-being, as well as most impact cost to the system. So that's one tool that we use. And also our claims data. So what chronic conditions are the most prevalent in our data set? Those are kind of the two things that we look at. And then third, we're working to align with the Covered California and DHCS on similar performance measurement so that we can act as one voice and try to place as much pressure on the healthcare delivery system to do a better job of managing those chronic conditions. So that's kind of the different elements in phases that we look at.
And most of those sorry, I did it again. Sorry.
I wanted to know how we look at managing maternal fetal outcomes.
I don't have that off the top of my head, but I'm happy to pose that question to Dr. Logan and get you a response.
Thank you. There tend to be very extreme racial and ethnic disparities.
Yes, there absolutely are. And for me personally, having a 17-month-old and a 7-year-old, this is of keen interest.
As it is me. So many women of color end up experiencing undiagnosed preeclampsia and suffering eclampsia, which means having a stroke or seizure during childbirth.
Yep.
So I would like us to look at that outcome.
Yeah, it's terrifying, and I agree.
Mm-hmm.
The other thing that's really interesting on that data is that the literature says that it, for a long time it was assumed it was correlating just to poverty. It's not. It
Nope.
correlates race irrespective of poverty. It's quite problematic.
Yes.
Which is why I think the data that we collect and the information we have relative to our claims data could be really informative on the notion of what further advancing the thinking on that it is not poverty related.
Mm-hmm. Thank you.
Not just poverty related.
Yeah, there you go. Thank you.
Anything else, Ms. Oliveros?
No, thank you.
Thank you. Mr. Rubalcaba again.
Thank you. Sorry, one more question. Ms. Olivares reminded me and some of the people. I know that at least with other employers, the insurance carriers provide like dashboards and utilization reports that show like how the trends in inpatient care versus outpatient, particular disease states or number instances of prenatal care, things like premature births, things like that. Maybe, and I'm sure you guys study them and everything. So maybe at some training session you can do like a profile of our demographics and what are the trends and what plans have been more successful, say tackling because I know they have apps and tools for like prenatal care, for example, or for controlling your weight. Maybe you can give some education on that at some point, and what tools are you using, what engagement are you doing with the carriers to make sure they're engaging with their covered population.
Yep,
Thank
absolutely.
You. That's a suggestion.
I think that sounds like a great idea, and we can definitely do some of that. Like that.
Very good. Thank you. No other requests to speak? No other questions? Anything else, Ms. Green?
Nothing more from me.
Mr. Moulds, anything else on this topic?
Not from me, no.
Very good. Thank you.
My gratitude to Ms. Green and her team for terrific work on this. Thank you.
Absolutely. We all share in that. So thank you, Ms. Green. Item 7B, long-term care program competitive strategy. Mr. Moulds.
Great. So good afternoon, Don Moulds, CalPERS team. This is the second of two discussions about mitigating potential long-term care rate increases. Yesterday, you heard from the investment team about their efforts to explore changes to the long-term care fund asset allocation as a way of potentially decreasing the size of the needed premium increases. Right now, I'm going to talk about the second way of mitigating rate increases, which is through benefit design changes. By way of reminder, we're contractually obligated to provide the benefits our members select when they enroll in the long-term care program unless they voluntarily agree to different benefits. So any benefit design changes that are adopted by the board would be optional for our program enrollees. It would ultimately be up to them whether they take them up. The goal of the benefit design changes we're going to talk about here would be to offer our policyholders benefit modifications, potentially available on their own or in combination, that would decrease the expected liabilities for those policies. These options would be made available to program beneficiaries seeking to forego some or all of a potential premium increase. The CalPERS team has modeled changes to current benefit designs with the goal of reducing their expected liabilities. Some of these include modifying the duration of elimination periods, instituting annual deductibles or other cost sharing, differentiating reimbursement by level of disability, and decreasing the daily benefit and policy duration. The modeling we've conducted takes the most common benefit designs in each block of the LTC program and then projects the decrease in expected liabilities that would be realized by changing them. So, for example, transitioning from a 90-day elimination period to a 180-day elimination period would decrease the expected liabilities of a typical plan in the largest LTC blocks by about 17%. Because we're able to reserve less money to pay future claims on a policy that includes that benefit change, the 17% decrease would translate to a corresponding decrease in rates. For planning purposes, we're assuming that some rate increase will be necessary. So our actuaries have been modeling packages of benefit design modifications to make available to members who want to buy down the expected liabilities of their plan in order to forego premium increases. I wish I could offer you details about what that reduced package would look like, but it obviously depends on the size of the premium increase we may need, the extent to which these options are employed, and the number of options that need to be employed will depend on the analysis and final determination of the premium increase that is necessary. Our goal, though, will be to offer a package that would negate a proposed rate increase for most program enrollees. In November, the final proposed premium increases required for each block will be presented in PHBC for adoption. The recommended mitigation options for policyholders will also be presented for adoption. If adopted, Any premium increase would go into effect no earlier than July of 2021. Most of the benefit design modifications we've modeled increase the cost exposure for long-term care program beneficiaries. That is, most of them increase cost sharing or increase limitations on coverage. We don't like them, and our policyholders wouldn't naturally choose them, save for the fact that they may be more palatable than a rate increase. We continue to pursue other options that would bring down the costs associated with long-term care by doing what we know both policyholders want and what is in the best interest of the CalPERS Long-Term Care Fund, supporting our policyholders in their home so that they can live longer lives with fewer disabilities outside of institutional settings. I look forward to those conversations in the near future. So that is, those are my remarks, and I'm happy to answer any questions.
Okay, thank you. Let me see. Mrs. Green-Ross, please.
Mr. Mulch, just wanted to say, you know, this is much appreciated, all the effort that you're putting into trying to resolve this complicated situation with no good options. So I just wanted to thank you and say how much we appreciate all the different ideas you're pursuing and efforts to try to keep the program going and keep the cost down. So thank you.
Thank you. I don't see any other comments or questions on this item.
Rob, excuse me. Rob.
Yellow.
We had public comment on 7A.
All right, I thought that was for 7B. That was my original note, but I will, as soon as we finish this, we'll go back to 7A for comment. Anybody else for comment on 7B? Seeing none. Anything else on this item, Mr. Molds?
No, that's it. Thank you.
Okay. Well, I hope Marta's still here. We're going back to 7A for public comment. Mr. Fox.
Yes, Mr. Chair, we have comments for 7A and 7B. We'll begin with 7A. Our first caller is Deborah Berger.
Yes, hi. I just want to make sure you can hear me.
Yes, ma'am.
Can you hear me?
Yes,
okay, thank you. Yes, my name is Deb Berger, and I want to comment, of course, on this portfolio rating risk adjustment. Marta Green made it clear that in November, that the CalPERS staff is going to ask the Pension Health Benefits Committee to adopt this form of risk adjustment called portfolio rating. And it was stated in her presentation that the board ended risk adjustment a few years ago because it was complex. But what the presentation didn't make clear is whether portfolio rating is going to be less complex than what was implemented in the past, and I would hope that this would be addressed. What we did learn about portfolio rating from this presentation for the CalPERS HMO plans is that it's probably going to ask CalPERS to make a very significant trade-off, and that it's going to drastically have less competition for pricing based on value. And the issue of value can be very subjective. So if you look at slide 24, it shows that CalPERS has 3 plans: Anthem Select, Kaiser, and United Health. And they have similar coverage areas, and it appears that they also have very, or rather strong competition amongst them. However, if portfolio rating is implemented, the slide shows that Kaiser isn't going to have any competition from a plan with comparable service area coverage. Not only that, Kaiser's going to have the lowest rate among the plans listed on the slide. So also, Anthem Select would become almost as expensive as Anthem Traditional, which is the other Anthem plan. Now, it was made clear in the presentation that back in July, there was a presentation before the board about a health plan competition study, and this is going to help determine if CalPERS has the right mix of plans for optimal competition. So the question that I have that I'm respectfully asking the board to consider and its stakeholders is that shouldn't they see the results of this competition study before they implement any form of risk adjustment? Isn't it important that the members and the stakeholders and the board be able to know this information? Now, many of us are still waiting to find out if the board already followed through with talks to Kaiser pertaining this issue. Other CalPERS Health HMO plans voluntarily lowered their 2021 rates, and they did this in response, of course, to the state and local government budget deficits.
Sorry, Ms. Berger, you run out of time.
May I finish with a question? There's a question of competition.
As long as you make it quick.
I will. Cover California got Kaiser to agree to a less than 1% increase in rates. Why isn't CalPERS pressing this? And it appears from the presentation that Kaiser will benefit because of a lack of competition.
Thank you for your comments.
Thank you.
Mr. Fox.
Mr. Chair, we have Joanne Hollander from RPEA.
Thank you.
Yes, this is Joanne Hollander, RPEA. Welcome and hello to the board, and Rob Beckner is chair, to the committee, excuse me. Good morning. I'm a little confused by the charts. I guess I don't quite get it as well as Henry, but one of the things I noticed that on the status quo, the premium projections for PPO basic plans, I sort of would like to have seen PERS choice laid out similar to page 5 of the charts so that you could see what was projected if nothing was changed among the 3 different plans of Care, Choice, and Select. And that would be really helpful. So that way I could compare it with some of the other models that you're projecting and talking about. Looking at the removal of PERS Care and then the merge of PERS Care with PERS Choice, there isn't much difference between the premiums between the two. So those are kind of, I don't see a big change there. So actually merging might be the two, might be the best way over the two, as opposed to just removing PERS Care. On the portfolio rating, I'm not sure what portfolio rating means exactly. It looks like on page 22, you have a aqua blue chart or column. You don't have it identified, but I assume that's PERS Select, and then it goes to PERS Platinum and Gold the rest of the years after that 2021. And I'm assuming you're getting rid of PERS Select, but it doesn't really say that here. And I kind of thought I heard that. So this is a little unclear to me, and I'm not sure what the makeup design would be to make this work between eliminating PERS Choice or combining it with PERS Care. I mean, PERS Choice, PERS Select, excuse me, I'm getting so confused. I've been really studying this material, and I'm sorry, it just doesn't come to me clearly. But I think that's an idea that should be pursued. I think the plan design is very, very important, and we haven't heard anything about any ideas on that. I do want to avoid buy downs and taking money from other funds to pay for PERS Care. We've got to deal with this mitigation. It is just kicking the can down the road, as they always say. I think it needs to be dealt with. I think staff is really trying to make an attempt. I know we haven't talked about this at all except for stakeholder meetings, so I'm hoping that some of us will have a chance to hear more details on this so we can participate. I think it's really important to get the feedback, but I think you came up with an idea on this. I think the PERS Select 70, I know you're not for that at all from what I heard. I'm trying to listen closely. But I think there's a lot of things that need to be sorted out here so it's simpler to review this. It is very, very complicated. And then you have the HMOs, which is a whole other thing. It looks like Anthem Traditional is going to be on the chopping block from what I'm seeing on your charts. But
your time has expired.
Okay, thank you. That's it. I appreciate it. Look forward to working with you.
Very good. Thank you very much. Mr. Fox.
Yes, Mr. Chair, now we have Mr. Larry Woodson.
Thank you.
Good morning again, Larry Woodson, California State Retirees. As I said in our stakeholder meeting, as well as the offsite, CSR really appreciates the work of Marta and her team on this issue, and we really support your work towards the goals that you've identified. I am confused at the difference in your presentation from the July meeting and today. In July at the offsite, there was a lot of the presentation talked about risk pooling, talking about Social Security, Medicare, Medicaid, covered California, all having risk pools that, and you talked about single risk pools and how the advantages of using a single risk pool versus what the old risk adjustment model was that CalPERS used previously. And yet there was no mention of that risk pooling in today's presentation. Back in July, there was no mention of portfolio rating. So I followed the portfolio rating discussion. I mean, it seems to, hopefully end up in the same place with the graphs using the various modeling. It did seem to level cost spread, and that was encouraging. And so I know that in stakeholders, you indicated that, or there was a commitment to meet with stakeholder groups, hopefully in the near future, to discuss some of these questions that have been raised. And also another concern I have is, shifting modifying benefit design is a concern, because that could have major impacts on our members or relatively mild. So anyway, I'll leave it at that. Thank you for the work you're doing.
Thank you for your comments. Mr. Fox.
Thank you, Mr. Chair. You have one more commenter on 7A, JJ Jelensik.
JJ Jelensik, RPEA. Risk mitigation sounds good. In fact, risk mitigation by definition is motherhood and gluten-free apple pie. But the real question is, what is the problem you're trying to solve? It sounds like you're trying to salvage PERS Care and Anthem Traditional. If you don't identify the problem accurately, you don't reach a good solution. The problem really is that you have different plans that offer different coverage at a different price point. And when you look at the things that they say, well, it's causing the shift in risk, every single one of the examples they use relates to those plan differences, the doctor network, the facilities, the areas. So really, what is it you're trying to solve? The complaint has been made that the members are not choosing based on value. They're not, but I will point out that objecting to the coverage and price trade-offs that the members make really is not particularly helpful. I will point out that in the case of the PPO, PERS controls the premiums, the benefits, the doctors, the facilities, the areas, and yet there's a big risk disparity there. So it's really not clear what the problem is. And I would also like to point out that for the long-term care, swapping lower benefits for a lower premium seems to not only be acceptable but desirable. And yet when we get to health care, that same trade-off is terrible, and we need to mitigate it away. So I really ask you to really give some thought to what is the problem you are trying to solve. If you don't identify the problem correctly, you don't reach a good solution. Thank you.
Thank you. Anyone else? Mr. Fox?
Mr. Chair, that concludes comments on 7A. But we do have comments. We have comments on 7B.
Very good. I'll be back to you in a moment. Mrs. Green, anything you wanted to comment on, or should we wait until November when you come back?
Oh, I don't remember every single question that was posed, but I would just
I'm sure
say,
not.
but I would just say that I'm looking forward to talking with the stakeholder community to both clarify their understanding of the issue that we're trying to resolve, as well as provide any clarity about the specific modeling. Also happy to show additional charts that show the progression of other plans as they continue to suffer the effects of adverse selection. One thing I do remember, and it's probably because Larry is near and dear to my heart, is he drew the distinction between portfolio rating and single risk pool. So the portfolio rating would create a single risk pool. So I use slightly different terminology because we have to use a different approach between the HMO and the PPO, but it would create that single risk pool like Social Security and Medicare that we discussed in July.
Very good. Thank you. So now back to 7B. We had just finished that agenda item. Mr. Fox, any callers for 7B, please?
Yes, Mr. Chair. First, we have Mr. Tim Behrens, CSR.
Thank you.
Thank you, Mr. Chairman and members of the committee. I continue to be disappointed in this long-term care product. I was hoping after yesterday's discussion that the investment team does actually ramp up and try to keep us from having those options that Don alluded to. While the options seem pretty straightforward, if you happen to be somebody that's had this product for several years and spent several $1,000s on it, and then you're given an option to pay even more money for it or reduce, and so then you don't get the same bang for the product that you purchased, it's a tough option to make. Having said that, I want to jump back to item B, because I wasn't down to speak on that initially until I heard Don talk about CalPERS staff reaching out to the stakeholders affected by the California fires. That is great. That's what you did last year. One of the things I did not hear you talk about was whether or not you also are going to provide staff in a centralized area to continue the medications coming and cooperation between pharmacies up there that will take all of our products, even though they may not be originally what we purchased. I really thank you and the CalPERS team for reaching out. I hope you will publish some kind of a document with phone numbers and contacts and email addresses. I'd like to reproduce that and put it in our paper so we can reach out to as many stakeholders as possible. Thank you.
Great, thank you. Mr. Fox?
Yes, Mr. Chair, we have Mr. Larry Woodson on 7B.
Thank you.
Good morning again, Larry Woodson. Thanks for the opportunity to comment, representing CSR. So the long-term care evaluation issue is on 3 different committee agendas. I commented yesterday in yesterday's meeting. The reduction, the proposed reduction in discount rate from 5.25 to 4% makes sense if your actual projections are going to be 4%. The discount rate ought to reflect that, and that's more transparent. Of course, the downside is that it has the effect of increasing premiums, which are already high. And the analysis, it seems like in developing that kind of a recommendation, you would have also determined what the actual rate increase would be before applying any modifications of the benefit design. And I'm just wondering why that wasn't included, and if you know it, what it was. Otherwise, I mean, generally we support your efforts. It's just, and it's difficult, as Tim said, to support more benefit design changes when it means less service and more premium. But I understand the options are limited. Anyway, my main point is, can you report out what the unaltered premium would be based strictly on the lowering of the discount rate? Thank you.
Thank you. Mr. Molds, do you want to add into that?
The only thing I'll say there is that we're not asking you today to alter the discount rate. One of the things that we're trying to do that I think we made pretty clear during the Invo conversation yesterday is improve that situation. So typically premium increases are attached to a rate increase or a discount rate that you adopt. So we wouldn't send out a speculative rate increase. That just doesn't make sense to us. Obviously, when we come back to you in November with asset allocation change proposals, and just to kind of follow up on some of the questions yesterday, we're not proposing that you change your authority to approve asset allocation. You retain authority to approve asset allocation, but when you do that, we will be landing on a discount rate at that time, and that will be associated with particular premium increases.
Very good, thank you. Anyone else, Mr. Fox?
No, Mr. Chair, that concludes comments on 7B. You'll have one more commenter at the end under 7D.
Thank you very much. So it takes us to agenda item 7C, summary of committee direction. Mr. Molds.
Thanks. So I have two items. One is share a list of chronic conditions we use in our performance measures with the board, which we're happy to do. Second was to queue up a discussion of chronic conditions by among CalPERS members by type and for discussion at a future board meeting. I'll also add just that we're happy to provide the pharmacy information targeted at fire victims on our website, and so that's available for everybody to see. It's an important thing to be doing.
Very good. Thank you very much. Seeing no other requests, moves us to 7D, public comment. Mr. Fox.
Yes, Mr. Chair, we have Al Darby, RPEA.
Thank you.
Good morning, Mr. Chair and committee members.
Good morning.
Hello, can you hear me?
We can hear you.
Okay. My comment relates to drug acquisition, the proposed new program to acquire drugs. In a recent congressional investigation, it was determined that a U.S. drug manufacturer was selling to pharmacy benefit managers in the U.S. a product at $150. The same product was found to be available in Europe at under $100, well under $100 in several countries, and amazingly at $35 in Germany. So my question is, will you add the dimension of looking beyond the shores of the U.S. to see what the drug pricing is in other countries, as well as using what you find from other countries as leverage to further bring down the cost of drugs? That's my comment. Thank you.
Thank you.
Thank you. I just wanted to remind Don that one other request was that the plan enrollment figures and trends also be shared with the stakeholders when they're presenting, explaining the the new rating methodology. Thank you.
Yeah, thank you.
Very good. Thank you, Mr. Rubalcaba. All right, seeing no other requests to speak, we're going to adjourn this meeting. The Finance Committee, since we are ahead of schedule, Finance Committee will begin at 11:20, 15 minutes from now. So with that, we are going to adjourn the PHBC meeting. Thank you all for being here, and we'll see those of you that choose to go to Finance there in 15 minutes. This meeting is adjourned.